Welcome, everyone, and thank you for attending today's HIMSS webinar, Reducing Readmissions to Improve Revenue, Care, and Collaboration, sponsored by DCS. During this webinar, you'll learn the positive impact a readmissions reduction program can have for a hospital in the financial care delivery and care team areas. Our first speaker for today's event is Dr. Thompson, physician liaison at Hahnemann University Hospital. And our second speaker is Tim Perkins, vice president at DCS. And so now, without further ado, I'd like to hand things over to Dr. Boyd to begin our presentation.
Thank you so much, ladies and gentlemen. I really would like to thank Mike and Patrick for doing such a fine job getting everything set up. And I would like to thank in advance my colleague, Tim. We would like to first welcome you. We want to really appreciate your time, and we really think this is just a really hot, wonderful topic to talk about. This is going to be in a discussion format so that Tim and myself will have the ability to actually add comments about each slide. So we're really going to try to share them. And we're also going to have three very interesting polling questions. When we ask the polling questions, we're going to ask that you respond as soon as possible because we would like to keep the flow moving fast, and we think that you will be certainly much more engaged regarding this. So after, we're going to go to the next slide, and we're going to start with the objectives. And Tim is going to take the lead on this.
Good afternoon, everybody. Glad to be on. Great topic, great discussion. We've done some great work at Hahnemann, and we're excited to be able to share it with you and discuss the impact we've been able to make. What we're going to talk about today is how this project came about, how we implemented it, the impact that it's having both from a financial standpoint, care delivery standpoint, and also how it's bringing together a diverse care team from not only inside the hospital, but the patient, patient's family, and members of the community care team as well.
Exactly. We're going to go right to the next slide. And we would just like to let everybody know that Hahnemann University Hospital is in downtown Philadelphia. We're an academic teaching institution. Our environment, we certainly are in an urban setting. We're just a few blocks from City Hall. And we have a pilot that we would like to discuss with you. This was with the Center for Advanced Heart Failure. And this is a group of very complicated heart failure patients. Many of them have devices. Many of them are up for transplant. So this is a special group of folks. In this city here, in this environment, we have rather unique payer challenges. Working with insurance companies is always special, and I'm sure everybody understands what that means. And as you can see on the slide, Hahnemann has won a number of national and regional awards. We're also a magnet institution. And you could see that things keep us pretty busy here. Tim, is there anything you'd like to add here?
Nope, great hospital, great history, and right in the middle of Center City, Philadelphia.
And I have to say, a few years ago, we just turned, we had a 200-year birthday. So you could say we've been around for a little while. Whoops. Tim?
Just a quick background on DCS, Digital Collaboration Solutions. We're a consulting and services company, and we work with healthcare organizations to improve care coordination on both the patient and provider side. We work specializing on improving patient-provider engagement. We do full programs. Sometimes it involves technology, sometimes it doesn't. And we have an in-depth experience in the healthcare field, and our goal is to make a difference for the hospital based on patient and provider engagement strategies.
Okay, Tim, I'll get the next slide here. Move it. I just want to set context here. And as you could see in this slide, right in the middle, you see the word patient and you see patient-centered. 2 days ago, on October 15th in Washington, D.C., it was a landmark day. All day on the FACA committees, the Federal Advisory Committees, there was a joint committee meeting of the HIT Policy Committee and the HIT Standards Committee. I'm typically on these calls, but this was a face-to-face, in-person call. There were literally, I would say, hundreds of people there. Topics there dealt with communication, such as interoperability, governance, and a bunch of other issues. But as people discussed these very important points, and certainly on the Hill, the people that do a lot of the funding say your systems need to talk to each other. The most important thing is that the patient needs to be in the center. This has to be for the benefit of the patient. So when we start to talk about the various slides that are coming up, we really want you to understand that the patient has to be in the center, and the patient is the focus of all these other programs. So if you're going to make a program change, if the patient's benefiting, something to consider. If the patient really doesn't benefit from some other type of program, you may want to put that on the shelf. So we really want to give you priorities. We want to set clear context that the patient, and you could say in the patient's family, is right in the center. Tim, I'm going to move to the next slide here. Here on this slide, we want to show you that when a patient, before they're discharged from the hospital, certainly ideally they have the appointment made. That means a date and time and certainly a location when their appointment is to be. Then on the far right, they have their appointment day, and we want them, obviously, to show up. We really want to compress or move the left and the right together so that the appointment made and they are seen at the physician's office. We really want that time to be as short as possible. That time after they're discharged from the hospital, we like to coin the vulnerable period. The patient is really set up for a whole lot of potential problems, such as medicines could be, as you see on the bottom of the slide, missing. There could be duplications. They may not get some medicines due to very high copays and deductibles. There may be issues with diet. So that vulnerable period, that length of stay at home, we really want to tighten up and make as short as possible. And we really feel that this has a lot to do with the setting of readmission. So again, this is in the context of our patient population. These are congestive heart failure patients, and we're really cognizant about their appointment being made, when they keep the appointment, and this interval of time is certainly one of the parameters we're going to be looking at. Tim, is there anything else you'd like to add to that?
This is the vision that we were presented with when we first talked to Dr. Boyd in Hahnemann Hospital. How do we get the patients in 7 days or less? How do we get them in quicker? And then what impact will that make on their readmissions? And how do we do that? And that's really was at the basis of the whole project.
And then we added, on top of that, can technology make a difference? By implementing technology, are we going to see some outcome changes? So I think we have an important slide coming up, which is our first polling question. Typically, the patients at your hospital are discharged with the appointment dates or appointments within 3 days, 7 days, 10 days, 14 days, that's up to 2 weeks, 20 days. Our patients aren't typically discharged with a follow-up appointment, and I have no idea. Okay, so we would like you to enter in really as soon as possible. So essentially, this is the length of stay at home. So if a patient is discharged within a time of, let's say, 7 days, hopefully they'll be back in 7 days, but it's unlikely they're going to be back there any earlier. So, okay, so we could see we're going to go to the next slide here. We're going to cut.
Hold on one second, Dr. Boyd, but there's still some things coming in here.
Okay. Okay, we'd like you to put in your results. We certainly would like a few more participants to, because we know we have a set of experts on the line here, and we would really like to see what your patterns are as far as getting your patients or our patients back as soon as possible.
And we have some interesting results that show the impact of how quickly they come back to readmissions.
Okay. All right, why don't we move to the results here?
Okay.
And what you could see, a good number of people, 25% it looks like, tried to get their appointments or appointments made in 7 days. There's some at 10 days, 2 weeks, certainly 19%, and then some say, I have no idea. So, Tim, is there anything else you would like to glean from this poll?
No, just the no idea. It would be good to know what that is. You'll see the link between that in the pilot results that we have, and also the the pilots are not, patients are not typically discharged with a follow-up appointment. That is, that's something that we should be thinking about. So go ahead.
Okay, we would like to let you know, describe the pilot. We have 284 distinct heart failure patients, and they span 554 discharges or 554 encounters. That means some people came back, more than once. We tracked appointment adherence. We also tracked whether or not they were readmitted to the hospital. But before we really started the pilot, and this was a 6-month pilot. We started near the beginning of Thanksgiving of 2013. But we said, what is our baseline data? So we went backwards from Thanksgiving, going backwards about 10 months, actually to January. So for the first, the majority, for most of the months in January, the first 10 months of January, what was the baseline readmission rate with this population? We had 26.7%. Don't forget, these are sicker patients, but this was the number. So now we're about 10 months out with the pilot. And Tim, would you like to mention something on the bottom bullet about the cloud and HIPAA?
So what we did is the 26.7%, excuse me, set a baseline. So that's what we were shooting at. Can we do better or worse than that, and if so, how much? And in order to manage the pilot, manage the messaging to the patients and to their families, we deployed a HIPAA-compliant platform from a vendor named Care Donation. We did a full functionality search and then comparison. And we chose Care Donation for the pilot, and it's cloud-based, HIPAA-compliant, out there in the community, so we can get at it. We'll talk a little bit more about that later, but that's the technology that we use, so we didn't have to use anything inside the firewall of the hospital to get this going.
Okay, we would like to show you the next slide, and really what's important on this slide is if you look at the slide, you can see that the patient is in the center, and the whole idea, again, this is for the patient. The patient's surrounded by a care team of different professionals, and that also includes other people such as friends and family. It could be your niece or your nephew or your spouse. So we really feel that family and friends are part of this relationship. You have various healthcare professionals. And then the little icons or cartoons towards the bottom, I think you could see a PDA or like a smartphone. You could see a computer terminal, a tablet, a telephone, and even like a regular computer where you could get email. So we want you to see that there are various devices of choice where a patient could actually choose how they would want to be messaged. It could be actually more than one device. We have other people, such as your niece or a family member, and this is also in 2 languages, English and Spanish. What we wanted to add also on this slide is that there's the ability, and it is being done, with bidirectional communication. So the patient, when they get a message, could actually respond back that they did receive the message. Tim, would you like to amplify that? Or?
Well, the one thing I'd really like to point out on this slide is that some people may think they already have this covered because they're doing robocalls. They're calling the patient at home, leaving a message on the phone, on the answering machine. And that has an impact. However, what we tried to do here was go in many directions at once. One is, can we reach more people that impact the patient, caregivers, friends, family, that want to be and are appropriately authorized to receive these communications? And then can we reach them in a way that it will get to them? And that means smartphones, texting, email, and also on the device of choice. So can we do it better and more effectively and get more people engaged in order to get the patient back in a timely manner? And also, we mentioned languages. It's very straightforward proposition to add a number of different languages to this too, so it's flexible in that regard. So we're really trying to go broader and deeper than just a call to the house.
Okay, on this slide, Tim's going to elaborate. We are going to summarize a lot of the things we just said. So Tim, why don't you go over these 3 boxes for us?
Well, on the appointment reminder, again, patient, family, and care team, so not just one call to one house. You can go text, voicemail, and email. Each individual can have their own way of being contacted. So the daughter might like text, the patient might like phone, somebody else might like email. Mobile phones, not an issue. Bidirectional, you'll see the impact of that in a minute. About people being able to just say whether they can make it or not. And it's we've integrated into the discharge process, and of course the technology needed to be HIPAA compliant, and this is, and it's cloud-based just makes it so much more accessible for people outside of the hospital.
Okay, we're going to start with some data now. And again, we just mentioned the top row, which is the baseline of 26.7%. And Tim is going to explain the 2.8% decrease target. That's the information in the top left in yellow. So Tim, why don't I let you go through this slide?
Yeah, the 2.8% decrease in target, I'll explain that on the next slide where we got that from and why that's a significant number for a target. But our actual results were through the 10 months was a 4.2% decrease in readmissions for those patients that were messaged versus a 26.7% decrease, 26.7% for patients who were not messaged. That is not that number is just by coincidence. The people who were not messaged stayed at 26.7. So people were given a choice. Did they want to be messaged? Did they not want to be messaged? There was some randomization that we did in there. And of the people who were messaged, 22.5% readmissions and 26.7% for those who were not messaged. And that equates about a 15.7% improvement in reducing readmissions over the 10 months.
Okay, Tim, I'm going to go to your slide that you alluded to from this paper.
So the 2.8%, where did we get that? Well, this is a paper that was done between the relationship between follow-up and readmissions on heart failure patients. And it was a study that was done 225 hospitals, over 30,000 patients. It was done over 3 years, and it was quite an extensive study. And the bottom line, what they found out was that those people who get early physician follow-up after discharge show a 2.8% decrease in 30-day readmissions. And that's the net of the study that we got out of it. It just reinforces. And we just show some interesting numbers that we got out of our smaller study, of course, which kind of back that up.
So essentially this is backing up that earlier follow-up, in other words, that length of stay at home, the shorter you get, the better outcomes you get as far as readmission. Okay, this is a very important financial slide. This is a general slide. It's applicable to multiple or many hospitals, not just our hospital here. But we really want to show you the economics of scale here. And this is certainly in accord with the Inpatient Prospective Payment Program that comes out every fall as a final rule. And Tim, why don't you briefly explain that from an accountant standpoint?
Well, before we did anything on this project, we went in and calculated a return on investment. And the way that we did that was we simply said, if we could reduce your chronic heart failure readmissions by 2.8%, what impact could that have on your penalties? So we did some analysis and some peer analysis. We looked at peer hospitals to Hahnemann's, and we said, what's their penalty rates look like? And if we could reduce yours by 2.8, what might that do for your readmission penalties going down, and then the amount of revenue you're able to recapture goes up. Now, as we all know, on the readmissions, there's tremendous leverage because a small handful of DRGs control how much you get back. So when we looked at this, we saw at over $3 million in revenue recapture for a hospital of about Hahnemann side, about a 500-bed hospital. And of course, we know that varies by each hospital and each readmission rate. So when we do these ROIs, we try to look at the peers in the same CMS region, et cetera, and come up with different numbers every time. But so far, it's been very very strong. That even at 2.8, what we can do. So far, we're tracking higher than that.
Okay, we would like to discuss with you, when we discuss communicating with patients, we offer them 3 venues. We offer them text. We would really prefer that. We offer them phone and actually email. It turns out that you could see the numbers. Just under 60% of the people prefer text, 42% of the people prefer phone, and just a few people prefer email. So again, I think when you're engaging patients, you really need to start asking preferences. Just as we said 2 days ago in Washington, you need to have a patient story. What is the patient's story? What are the patient's preferences? So I think being able to have modes of communication that are best suited to the patient are certainly something that's important. So Tim, may I go to the next polling question?
No, hold on one sec. I do have a couple points on this slide. When we originally started it, we thought it was going to be 80% phone. And we were also questioned about, with Hahnemann's patient population, a high disadvantaged share center, will these people have phones? Well, the answer, number one, is that yes, these people have phones, even if they're the government phones that they sign up for. So they have phones, and they do text. And the second one is that there was a fairly high number of texters over phone. So we had some preconceived notions going in, but those in the reality is that a lot of people have phones, even people that you wouldn't think would be able to afford one. And then there's a lot more texting going on, even with an older population, than you might think.
All right. I think we need to get some information from the experts attending today. The average days between discharge and subsequent readmissions at your hospital for heart failure patients is. In other words, when somebody goes home and then they're readmitted back for heart failure, how long did they stay at home? Were they at home less than a week? Were they at home a week, week and a half? Did they tend to come back in 2 weeks? So exactly how long were they at home before they came back? So that's a pretty, it's an interesting question, and we want to show you some data related to that. But we would first of all like to hear what your experience is. Okay, we have just almost, not quite, half of the attendees responding. We certainly would like to have a little bit more data here. I'm sure all the statisticians on the line would like to see significance, so the more data, the better. So, okay, why don't we, okay, we're just getting there. Let's go to the next slide, and we're going to close it. And you could see that readmissions here in this group, that's less than a week, between 0 and 5 days, between 6 and 10 days, there's 6%. And then you could see after that first hurdle of days, it kind of drops off. And then some people say they don't have, maybe this question is not so relevant. Tim, is there anything else you want to say on this, or can we keep going here?
No, this is interesting. Keep going, because we're asking you because we want to show you what our experience was.
We're actually interested in what your experience was, so this was a good question. All right, over 555 encounters, the average length of stay at home, and between attending, when we say attended, we mean they showed up and attended their appointment. So between going home and getting into your first appointment, an average was 15 days. Those patients that were messaged, they came back on average in 9 days. Those patients who were not messaged came back in about 19 days. So I think you could see the difference. When you're messaged, you tend to come back quicker. When you're not messaged, you stay out a little longer, increasing that vulnerability period where all those, I'll say bad things or things can happen. The average days between discharge and a subsequent readmission was 15 days. And you could see those messaged were 16 days and not messaged 14 days. Tim, can I continue?
Yeah, the two things here. One is that the staff making the appointments, that was done blind. They did not know whether the patient was to be messaged or not. So they just got the next appointment. And this includes reschedule. So some people who were messaged, perhaps they were messaged, they said, you know what, I can't make that day. They would call and they would reschedule. But some of these people were not messaged, didn't reschedule, they either canceled or no-showed, or it took them a lot longer to get in the door. And as we're finding is, if your average is 19 days to come back and your average readmission is 15 days, then you're going to get a lot more readmissions. You're not going to be able to catch those issues up front and prevent the 30-day readmission.
So that's an important point. The professional staff on the outpatient side was, they did not know which patients were messaged or not messaged. This is an important paper from the group up at Yale, led by Dr. Krumholtz. And we want you to look at the third little really thin line at the sort of in the top where it says days 0 to 15. And the percentage of all readmissions are 61%. And that is for heart failure patients. Patients coming back in their study between 2007 and 2009 were over 329,000. Those are readmitters out of about 1.3 million patients. So that's a whole lot of patients. But we clearly want you to see that 61% of these people in this study came back by day 15. Between 0 and 3, remember on the poll there were a whole lot coming back between 0 and 3 and 0 and 4. Here, 13%. So really between 10 and 15% of the patients come back at 3 days, little over 30% come back within a week, and here in roughly a day over 2 weeks, 61% come back. So this is a baseline, and we're going to show you what our data looks like now. Tim, I'm going to go to the next slide and show them ours.
Sure.
So if you look at our data at where it says 0 to 15, what percentage came back within 15 days? We have 60%. So it's kind of amazing that it sort of validates a previous model that 60% of our folks are coming back in 15 days. But we really want to let you know that 60% is cut up into 2 pies or 2 segments. Of that 60%, you could say a third of them were messaged and 2/3, 41%, were not messaged. So we think that patients are being messaged are less likely to be readmitted. Tim, would you like to glean any more from this?
This was insightful in that we looked at the Yale study and we said, can we recreate the same slide in the Yale study with our data? And that led to some interesting insights, especially the 60%. That's 1% difference is amazing. So,
well, I think the next slide is going to be very instructive. We want you to look at the bottom row. 35% of patients. Now, we're talking about readmission. So in the top middle, we're talking about readmission rates. That's the deal here. So on the bottom left, 35% of the patients were readmitted like within 1 to 7 days.
No,
go on, Tim, why don't you go over this?
Yeah, no, what we wanted to show on the bottom was that this shows you how the patients were seen. 35% of all the discharged patients were seen within 7 days. 46% were seen between 8 and 14 days. 14% between 15 and 21 days. And 6% of all the discharged patients that attended appointments were seen between 22 and 30 days.
So those patients that came back to the clinic within 7 days, 35%, had 11% readmission rate. Those people that came back in over a week, between 1 to 2 weeks, had a readmission rate of 31%. And as you can see, when your clinic follow-up is longer, your readmission rate seems to be higher. Tim, would you like to?
No, just a very interesting slide, which just follows the point that you want to get them in. You get them in within 7 days. It's a lot of things, as Dr. Boyd says, you want to lay eyes on them. There's a lot of things that you can correct or get straight or get medication straight or that you can fix and address to keep the 30 days down.
Want to put something into perspective? This may be on the cutting edge, but for many people, and this is in heart failure patients, They want those patients seen within 5 days, some places within 3 days. Some places are even offering same-day appointments. Some people could be discharged potentially in the morning, and they may even see an outpatient clinician or professional, maybe even later that afternoon, just to make sure everything's okay. So the fact that the length of stay could potentially be reduced to 1, 2, or 3 days may have a whole lot of validation, because you could see here that when they come back to the office in a shorter time, their readmission rate is less. And you can just imagine all of the confounders that are behind this. Tim, can I go to the next slide?
Please do.
All right, we've talked about messaging, and we mentioned earlier that patients can confirm. So we have a group of patients that were messaged and they confirmed, potentially the most engaged. We have patients that received the message, they didn't confirm, and then we have patients that were not messaged, and obviously they were not confirmed. So the readmission rate for this group was about 8.8%, and those that were messaged and confirmed, those were, and then you can see 15.4% for the rest of the group, and then it was about 23% in the group that was not messaged at all. So that's pretty clear. Now, as far as attending means showing up in the office at the prescribed time. So if you were messaged and confirmed or just messaged at all, you came back to your appointment, not too bad. But you could see that you less than 50% of the people came back as wished if they were not messaged. All right, and then we're going to go to the next one. Cancellations. I don't want to say cancellations is a problem, but cancellations can be a problem. Those people that were messaged canceled to some degree, but you could see almost twice as many people canceled who were not messaged. Tim, is there anything you could say about these 3 slides we just went over?
Well, we just wanted to ask ourselves, the people who use bidirectional and talk back to us and confirm, was there any difference? And we found a really significant difference. The other is that we all know the costs of no-shows. So if we can keep the examining rooms, keep the capacity up and keep the volume flowing, we know that it's not only good, it's good for the follow-up. It's good for the readmissions.
Okay, we have a polling question. The top 10 readmitters at your hospital for heart failure. So that means you probably have the top 10 are responsible for what percentage of readmissions in your hospital? In other words, if you would look at the top 10, they're coming back. Of all of those that come back, what percentage do these patients represent your total readmissions for heart failure?
Take your best guess.
Okay, we'd like a few more respondees because we want to keep moving. We want to show you some really cool results and some neat takeaway things that one can do to theoretically change this rate. Okay, we have just under 50%. Let's just go look at the questions because I'm a little hasty here. So some people think it's only between 0 and 10%, 6%, 3%, 11 to 20%. We have between 21 and 30%. That's 21% of the folks. Tim, is there anything you'd like to say on this?
No, interesting. There's first thing is you should know, you should try to know, do some analysis on it, because when you start getting into profiling in a positive way and trying to identify those patients that need the best care to prevent readmissions, you really need to understand the what's happening before you can arrive at a program like that.
I want to look at that 21%. There are a lot of people feel that the top 10 patients are responsible for 21% of their readmissions. I want to put a little tag on that. Okay, this is what we found with our study, and this slide and the next one are really rather important. We're going to look at people that came back twice. That's 15. Did you know 6 patients came back 3 times, 1 patient came back 4 times, 1 patient came back 5 times? That includes 23 patients, which is about almost 9% of the patient population. And you could see this represented of readmissions 63.2%. We're trying to show that a small number of patients make up a significant amount of your readmission rate. Tim, can I go to the next slide, which is more explanatory?
Please do.
And then on the next slide, how many of your people have come back 3 times, 4 times, or 5 times or more? You could see 8 patients came back so many times. They represented, Tim, would you like to go into this in a little bit more detail here?
It's very straightforward. 8 patients are responsible for 30% of all readmissions in the study.
Okay, so a small number of patients are making up a whole lot of readmissions. We want you to think of data analytics. We want you to think of predictive modeling. Basically, you can see when they are back, and you know who's coming back when they're back. These people are different, and we want to try to go into those differences a little bit. At least we think they are. So where can we go from here? We would really like to expand mobile technologies, and certainly more than one direction. We feel that mobile technologies have an important role not only on clinical impact, but also upon finances. The next slide, we feel that there's also a lot of potential regarding a medication adherence program. That is that vulnerability period. Are the patients adhering to their medicines? Are the directions confused? Maybe they don't even have the medicines as you think they might occur. And as you could see, medication adherence, according to CMS, is still very important and costing billions of dollars annually. Tim, is there anything you'd like to add on these 2 bullets here?
It's just that these make sense. This is where you're going to get the biggest bang for your investment and payback. And going after making sure people are showing up, making sure they're showing up on time, anything you can do there will reap big dividends. The second thing is medication adherence. That's another 11%. So if you're going, make sure they get there, make sure they're taking the medications. What kind of focus programs can you put on a very small number, manageable number of people that are impacting a big percentage of your readmissions? You do those 3 things, you're going to really start to impact your readmission rate. And if you do number 1, you're actually going to recover some revenue to help pay for the rest.
We also feel that it's important to enable care team collaborating with the care team, and also people that are outside the hospital. The professionals outside the hospital are very important. And don't forget, in this IPPS role for the value-based purchasing, the hospital is at risk. So it's very important that the hospital begin to leverage all of these other professionals, because the hospital is going to get dinged on their Medicare reimbursement for all DRGs. And again, the other professionals that you could leverage are listed at the bottom of the slide. If you talk to visiting nurses, you talk to visiting OT, PT, speech people, all of them are concerned about readmissions. They have a pool or population of patients. They have very intricate quality statistics and metrics they're keeping, and they know that their viability, their ability to have a lot of patients will depend upon their outcomes. So they're really willing to bond to a hospital group that could work with their patients when the patients are in the outpatient setting. Tim, is there anything more, or can we go to the next slide?
Let's go to the next slide.
So in a bigger frame, we want to talk to you about enabling the care team, and Tim is going to talk about that. That's what his company is expert at.
What we found are in the study was once we are able to identify the patient and identify a way to communicate with the patient and the caregivers and their family and friends, and we receive the HIPAA approval to do so, and we're wording things properly, And now we've opened up another channel of communication above and beyond what's traditionally been there. So the technology that we deployed also allowed us to let people from the outside in a secure manner. So leveraging the platform that got a return on the appointment adherence, we're now able to extend information about the patient out into the community. So now we want to begin, one of the things we're going to start doing is starting to talk to the visiting nurses, right? And how can they start putting progress notes in? How can the PCP come in and look at information? And all this is very simple. They have a sign-in. They come in. They sign into a secure portal, and they can see the information. They can add information. It can be restricted to just the patients that belong to them. So there is really a community-based platform here where people can begin to share information. And whether you're the caregiver, or whether you're a clinician, or whether you're a patient or a friend of the patient, you can share information. Of course, there is a security in that some of the clinical information is not seen by the friends and the family, but the clinicians can certainly share. So
on this slide, I just want to mention on this slide, you could see the patients in the center, and a lot of the care team that Tim is talking about are circling the patient. Again, the whole construct of the patient in the center. Care Donation is the application we're using that Tim talked about. And then security-wise, Tim could talk about, this is, again, we mentioned this is cloud-based, it's HIPAA compliant. Tim, is there anything you want to mention on this slide?
This is our direction. What we realized with the appointment adherence, we began the conversation, and now we want to start thinking about medication adherence, layering that in. So this does not have to be a big bang approach. You can start simply, and then the technology that gets in place can be leveraged and used for other things and be expanded. And it's a way that we get it out there in the community, get people sharing, and now we want to use it for transitional care as well. So they have that place where they can connect without having to do expensive integrations, one by one, especially if you're a skilled nursing facility or a relatively small visiting nurse setup. But now they can become a part of the conversation.
Okay, I'm going to go to our next slide. So in conclusion, we would like to mention that patients that were messaged, and certainly those that responded, seem to be more engaged. They seem to be more engaged in their care, and you could see the metrics for readmissions, attending their appointments were certainly much better. They canceled their appointments less. So we really tried to show, and we confirmed that earlier follow-up is very important. It affects readmissions, and that the whole idea of expanding care coordination among caregivers, but actually most important near the bottom, we want you to see, and this has been confirmed, and some people call this bending the cost curve, that there are a small number of patients by number that represent a huge proportion of those contributing to the high readmission rate. In other words, your readmission rate is being contributed to by a very small number of patients. And specifically, we feel that these patients still need technology. You don't want to deprive these folks of technology, but they need to be hit with the Army, the Navy, the Marines, the Coast Guard. So all of those professionals that are at home potentially could be, I think there's opportunity there. These folks need perhaps an increased number of the traditional, hands-on. Maybe they need to be seen at their home every single day by somebody, but they tend to need a huge hands-on type of environment. That's not for all your CHF people, but we're saying, like in our group, it could be that top 8 that are making such a huge contribution to the readmission rate. These are the people that need everybody that can come out there. Tim, can you add to that?
No, that's great. We agree.
Okay, so that's so basically there's also a lot of science about patient-generated healthcare data, PGHD, We really try to say that patients that are more engaged, patients that can write, patients that can make a contribution about their care seem to be a special group of folks that tend to have better quality metrics. They tend to have less cost, so the cost or financial metrics are better. And then other people or regulators would translate that into value. So again, we really feel that you could do a whole lot as far as clinical care, increase quality, decrease costs by enabling technology. And if you could align technology not only with clinician and patient workflows, we feel that there's a significant opportunity there. We would like to give credits to a whole lot of folks that you see listed there. We certainly feel that this takes a team, and we really appreciate the time and the expertise and all of the extra resources that these folks have given us in the program. Okay, so I think that, one more slide here. And we would really like to open this for questions right now, if possible.
Okay, thanks to you both for a really informative presentation. It was very interesting stuff. First question up. Someone's wondering whether you could explain a bit how you're executing your medication adherence pilot.
Medication adherence is something that it's really in the future tense. This is what we would like to do almost next. What we have been doing is messaging patients right now with their appointment, and there's a certain algorithm that goes off early in the time, sort of in the middle, and then closer to the appointment. So right now we've been messaging this. Tim could elaborate with this company how they're actually working with medication adherence.
You know, we were part of the pilot to prove the efficacy of mobile patient reminders for appointments. We just kept it to that, and now we are expanding. So we're just in the early stages of discussing what a med adherence pilot would look like. The technology that's in place has the capability of doing it. So now it's getting it as we're rolling out appointment adherence to the other services in the hospital. We're also rolling out a pilot on med adherence, and then we'll understand how we do that a little bit better and measure that, and then we will roll that out afterwards. So none of this has to happen one on top of the other. They can happen in parallel. But that's what we believe after appointment adherence is the next big chunk. That's 11% according to CMS. So if we can get a handle on that while we're improving appointment adherence, then we're really accelerating our results.
Okay. Next question.
Someone else is wondering, when messaging your care teams, how do you avoid messaging fatigue on those providers?
First of all, the message algorithm is not a lot, so they're not getting a lot of messages over a period of time. It's really rather light. So, Tim, would you like to say anything about that? We started with 3. So you get an appointment. When the appointment's made, you get one right away, and then the day before the appointment, you get another one, and then somewhere in the middle, you get a third. And we didn't know whether 3 would be too little or too much. And throughout the pilot, we did not hear one complaint that you're getting to me too much. So we probably could have gotten away with another 1 or 2 in there, but we thought 3 was appropriate without sending him something every day. We also had a capability that if the appointment was made within 72 hours, then we would only hit you twice. We'd hit you right away in the day and right before, so you didn't feel like you were getting 3 jammed in a 48-hour period. So there's actually a rule in there. So depending on what your discharge date is and when your first appointment is, if that is a short time, you would get fewer messages. If that's a longer time, then you would get more messages.
And that's adjustable. Now for the PCPs, we have this is another part of what we're beginning to roll out, but it wasn't in the pilot, is that we can let a care team know, a provider, either by text or by email. So the idea there is that it wouldn't be we're texting a PCP all the time when one of their patients is in the hospital. We can actually, what we do is we send them an email with a specific link, a custom-built link. So when they click on the link, they come to the front of the portal, they sign in securely, and then it brings them to that patient information.
One of the most important points about a health information exchange, at least from a PCP or primary provider's perspective, would be most of the PCPs, who don't see their patients anymore in the hospital aren't even notified or messaged. They don't even know when their patients are admitted or discharged. And that's one of the opportunities one could have in a big health information, network. But basically here what we're trying to do is we would like to be able to message a PCP that their patient's in the hospital, when they're going to be going home. And so certainly a PCP's mode of communication, many of them probably don't want text, but they would probably, more of them, a greater percentage would probably want email. Don't forget PCPs often are important, let's say in this case, with the establishment and creating of referrals and so on, but really trying to get your PCP and that specialist relationship even, closer together is something we would like to do.
How do factors such as patient age or acuity or an insurance coverage figure into the study?
Well, we did it for everybody, so all comers, so there really wasn't a problem as far as payer or insurance coverage, so this certainly didn't affect cost. I'm sure if there's less readmissions, the payers are happier. We did everybody. Regardless of their age, we tried to sign them up, and you could see the statistics there. Many of them were enrolling with text, the others, with their phone. So I think everything was pretty transparent as far as that went. Tim, is there a comment you'd like to add to that, or?
No, we didn't look at insurance. We didn't look at age. I did do a quick look at the baseline data to confirm that the age didn't really factor in, and in fact it didn't. I looked at people over 65 and people under 65, and the overall readmission rate was very, very close. It wasn't dramatically different at all. So for our purposes, we wanted to test appointment reminders and does it get them in faster and does it make an impact on readmission. So it worked out well on that. We wanted to get some significant numbers so we could get the 95% confidence level at a low plus minus.
One more before we wrap up. Someone's wondering, are you having success with feedback that a message has been received? In other words, robocalls probably aren't really a good thing for this, right?
What we have done, again, the person ideally gets a text message, so or they could get a phone, and using either of the two devices, they can push a certain key to notate that they're confirming. So that's how they're doing that right now. Tim, would you like to add to that?
I think you saw in the slides that the difference in readmissions was 8.8% for those people who were both messaged and confirmed versus about 15, 16% for those people who were messaged but did not confirm, and then it was significantly higher for those who were not messaged or confirmed. That's precisely the question we were trying to answer by looking at that data in that cut. Does it make a difference? And the answer is it absolutely makes a difference. And it also tells us a lot about the impact that the engagement of a patient can make on the outcomes.
And we really feel that the ability to confirm is related to the level of engagement of a patient. So I think those patients that are more engaged certainly would be more likely to confirm than someone else. And again, it just goes over a lot of the statistics, especially a lot of the scientists from up in Oregon, will show that those people that are really engaged tend to have better quality metrics, their costs are down, and they just tend to do better. And the relationship often between the provider and the patient is actually closer and better versus a patient who is less engaged.
Toward that point, just one more, quick one. Have you surveyed the patients and their families about all this, and do they like it?
We've been getting positive feedback. They tend to really like it. They seem to be engaged, and what Tim said, we haven't had any negative feedback at all on that. So there's been 0 negatives, and people really like it. And I think people nowadays are almost expecting something like this.
The people who really like this are the family members, the people who previously the phone call or robocall went to the house, and they never got it. They didn't know when their parents' follow-up appointment was. I can tell you from experience driving both my parents to doctor's appointments, I certainly would appreciated a confirmation call, which I never got. So those are the people who really say, yes, I have a stake in this. I'm going to help take care of my mother, my father, my uncle, my aunt. And it brings them into the conversation. So
and Tim is right. We're talking about a conversation. We're talking about things going back and forth. But more important is if you have a text, you can go back and receive or retrieve the text and see the information that you need as opposed to trying to remember something.
Right. And the care team members can respond as well and confirm. So you could get multiple confirmations that the patient's going to make it, or the daughter is responding and saying, yes, I'm going to make sure my father gets there. They're a full part of the conversation.
Okay. Well, this has been a really terrific presentation, so thanks again to you both, and thanks again to the audience. If you would like to view the archive of this webinar or share it with a colleague, please visit the on-demand webinar section on HIMSS.org. Thanks again, and have a great day.
Thank you.